Hello, everyone. I'm Aditya Bardia. I'm a breast medical oncologist at Massachusetts General Hospital. And today I'm excited to talk about current strategies for management of patients with ER positive metastatic breast cancer. So I'm a medical oncologist, thought would start with a patient story. This is a 65-year-old female who had ER positive HER2 negative localized breast cancer, received adjuvant endocrine therapy with exemestane as she was postmenopausal, and then unfortunately a few years later developed disease recurrence in the bone. So as we would recommend, patient receive letrozole plus a CDK4/6 inhibitor as first line. That worked for 2 years, and then the patient had disease progression. So the question is, what therapy would you consider next? There are options: fulvestrant plus a CDK4/6 inhibitor, exemestane everolimus, or need more information. So let's address the first point, which is whether CDK4/6 inhibitor should be continued in this patient. So we now have conflicting results. The MAINTAIN trial looked at fulvestrant plus ribociclib in patients who had received prior CDK4/6 inhibitor. So very similar to this patient who got AI letrozole. The trial looked at fulvestrant plus ribo versus fulvestrant alone and showed an improvement in progression-free survival with the use of ribociclib. And majority of patients in the trial had received palbociclib. So it was a switch in both the endocrine therapy from an AI to fulvestrant, as well as switch in the CDK4/6 inhibitor from palbo to ribo. On the other hand, the PACE trial looked at the same question with negative results. That trial looked at fulvestrant plus minus palbociclib and showed that there was no improvement in progression-free survival. In PACE, majority of the patients had received prior palbociclib, so maybe part of the reason the trial was negative was because the CDK4/6 inhibitor was the same. There was no change in the CDK4/6 inhibitor. We'll have the final results from the post-MONARCH trial, which would address this issue, and that's a pivotal phase 3 well-powered registration trial looking at fulvestrant versus fulvestrant plus abemaciclib in this setting. So right now, it's a controversial area. Some physicians will continue the CDK4/6 inhibitor, especially in patient who wants to continue CDK4/6 in patients who have visceral disease. How about this patient? I think the correct answer for this patient in terms of what to do second line would be that we need more information. So this patient had received endocrine plus CDK4/6. We need to get plasma-based genotyping because we need to know the mutation status of the tumor before deciding what to do next. So I would say the correct answer right now is we need more information before we make a therapy decision. And the more information relates to genotyping. So that's exactly what was done for this patient. The patient had plasma-based genotyping, which revealed a mutation in the estrogen receptor. So what are ESR1 mutations? ESR1 mutations are essentially mutations that mediate resistance to aromatase inhibitors. They make the tumor estrogen independent, but still dependent on ER. So drugs that directly bind to ER would in principle work, while drugs that lower estrogen, like aromatase inhibitors, would not work.
Just to clarify, in terms of the workup here, would you not want to see a PIK3 assay?
Absolutely. So the idea with plasma-based genotyping would be to look at different genes, including PIK3CA, including ESR1 and other genes. So this patient had plasma-based genotyping, which showed mutations in ESR1, and there was no mutation in PIK3CA.
Just out of curiosity, what's the false negative rate? I mean, I'm sure it's variable with plasma, ESR1, and PIK3. If you go to get tissue, for example.
Yeah, in general, the false negative rate with these sensitive assays is very low. If anything, you're much more likely to pick up these mutations by plasma-based genotyping rather than tissue in the metastatic setting, because plasma can address the issue of spatial heterogeneity. So there are different lesions, some of which have mutations, others don't. If you do a biopsy, you can miss that, but in plasma, you can capture the different mutations.
Please continue.
So, what are ESR1 mutations? Essentially, ESR1 mutations make the tumor estrogen independent. So, drugs like aromatase inhibitors don't work, but drugs that directly bind to ER, like SERDs, would work in this setting. So this has led to interest in development of a number of endocrine agents. An example of a drug being elacestrant, which is an oral selective estrogen receptor degrader. In a phase 1, phase 2 trial that we were involved with, showed impressive clinical activity in patients who had received prior therapy, particularly patients who had detectable ESR1 mutations. So this led to the phase 3 trial, the Emerald trial. The Emerald trial was a trial looking at elacestrant versus investigated choice of therapy. Majority of the patients got fulvestrant in the trial if they were randomized to investigated choice of endocrine therapy. This was a trial in the second, third line setting. So the patients had received prior endocrine therapy with a CDK4/6 inhibitor that was required in the trial. The trial had two primary endpoints, one progression-free survival in the overall population and progression-free survival in patients with detectable ESR1 mutations. The hypothesis was that in patients who have detectable ESR1 mutations, that's where we should be able to clearly see a signal given the use of this agent, elacestrant, that targets estrogen receptor. So what were the primary results? The trial met its primary endpoint. There was improvement in progression-free survival. In particular, for patients who had detectable ESR1 mutations, you could see improvement in progression-free survival. Looking at the curves carefully, you see that there's an initial drop in both arms and then separation. So this highlights that there's a subset of patients who have endocrine resistant disease. This is the second line plus setting. So a subset of patients have ER independent disease, and in that setting, endocrine monotherapy is not going to work. But in patients who have endocrine sensitive or ER dependent disease, that's where endocrine monotherapy could work. And so in the endocrine sensitive setting, later on, you see separation of the curves. So in this setting, PFS rate is a better metric. And if you look at the PFS rate at, say, 12 months, it was 26% with elacestrant versus 8% with standard of care. This brought up the natural question in terms of, can we identify the patients who have this initial drop in the curves, which is endocrine resistance, versus patients who have endocrine sensitive disease? And one simple biomarker appears to be prior duration of CDK4/6 inhibitor. Because patients who have disease progression within 12 months of CDK4/6 inhibitor in the first line setting generally have more endocrine resistant disease. And the other way around, in patients who are on endocrine plus CDK4/6 inhibitor for more than 12 months, generally have more endocrine sensitive disease. So if you look at patients who were on CDK4/6 for at least 12 months, you see early separation of the curves, a PFS rate of 35% with elacestrant versus about 6% with standard of care. Median PFS now, because of this early separation, which is much more meaningful, median PFS of 8.6 months with elacestrant versus 2 months with standard of care. So some physicians consider this as a biomarker when deciding whether to use elacestrant or not, which is the prior duration of CDK4/6 inhibitor. So these results led to the approval of elacestrant. Elacestrant is now FDA approved for postmenopausal women or adult men with ER positive HER2 negative disease who have detectable ESR1 mutations based on a companion diagnostic. The FDA mentioned Garden 360 as the companion diagnostic in clinic. Sometimes we use other assays as well. This is in the second line plus setting. There is no upper limit in terms of the prior number of endocrine or systemic based therapies. The FDA did not require the prior duration of CDK4/6 inhibitor in the label. It's something that some physicians do, but as a reminder, it's not required as per FDA label. Now, besides this, there are other drugs in development, giredestrant, imlunestrant, camizestrant, just highlights that there are other oral SERDs in development as well. We just need to be very careful with cross-trial comparisons, given that there could be differences in prior lines of therapy and tumor biology, but speaks to the excitement related to oral SERDs in ER-positive metastatic breast cancer. So let's come back to this patient story. This patient who had endocrine plus CDK4/6 inhibitor, we obtained ctDNA analyses, the patient had detectable ESR1 mutation, no detectable PIK3CA mutation. The patient started therapy with elacestrant and is currently doing well on the therapy with elacestrant.
So I have a question about ESR1, and I'm trying to remember exactly what Erica said to me because I just recorded her thing yesterday. But I think she said a lot of people, there's a lot of debate and a lot of people disagree with me, but I think she said that she viewed ESR1 as a marker of estrogen sensitivity. So my question to you is, if you take that same clinical scenario of second-line therapy after AI CDK, when you look at the patients who don't have ESR1, do they respond to endocrine therapy?
Yeah, so good question. I agree. ESR1 mutations are a surrogate marker of ER dependency. It tells that the tumor is still likely dependent on the ER pathway. But there could also be tumors that do not have ESR1 mutations that are dependent on the ER pathway. So the absence of ESR1 mutations does not mean that the tumor is not endocrine sensitive or ER pathway dependent. And even in the Emerald trial, there were a subset of patients who had ESR1 wild type tumor that did well on elacestrant as compared to standard of care.
So, has it been tested in patients who, are ERS wild type or don't have the
In the
mutation?
Emerald trial, there were a subset of patients who had ESR1 wild type tumor. You could see benefit with elacestrant in some patients, not all patients. It was a secondary endpoint, so did not meet statistical significance. And I think what we need is biomarker to identify when you have ESR1 wild type tumor, what's the subset that's still sensitive to endocrine monotherapy in this setting.
So, I guess I'm thinking those patients who are ESR1 wild type, would the duration of time on the CDK be predicted the same way it is with mutant patients? Is that a way to kind of figure out whether they're endocrine sensitive?
Yep, that's a good question. And that was looked at in the Emerald trial, and that did not appear to be a marker that could predict who would derive benefit from elacestrant in the ESR1 wild type setting. I think we need different biomarkers in that setting.
Interesting. Please continue.
So let's talk about a second case now. This is a 55-year-old female with ER-positive metastatic breast cancer. The patient had disease progression on various endocrine-based therapy and then received capecitabine and paclitaxel. Excellent performance status, germline BRCA negative, PIK3CA and ESR1 wild type. The tumor HER2 status was 0, so it was not a HER2 low tumor. The question is, what therapy would you consider next? Eribulin, vinorelbine, sacituzumab govitecan, or trastuzumab deruxtecan. I put in the hint, it's not a HER2 low tumor, so at this time we would not consider trastuzumab deruxtecan. I think many of us would consider sacituzumab govitecan in this setting.
Do you think that responses are seen with, quote, HER2 zero? And are there really patients who are HER2 zero? Like if you look at multiple specimens, can you usually find one that has, IEC of 1 plus? So in other words, really, is IEC zero really a roadblock for you here? I mean, I can understand why maybe it wouldn't be your next therapy, but I mean, would you use TDXD in a patient who is HER2 zero?
That's a good question. So in the Destiny Breast04 trial, any prior HER2 low status was included. So if you have any biopsy specimen, primary or metastatic or latest biopsy, which shows HER2 IHC 1 plus 2 plus, you can use trastuzumab deruxtecan. Here and there, we do have patients who do not have any biopsy with HER2 IHC 1 plus 2 plus. And so in that setting, as per FDA label, you cannot use trastuzumab deruxtecan. But there are ongoing trials, particularly Destiny Breast06, which is looking at trastuzumab deruxtecan in IHC HER2 zero. And if that trial shows benefit, then I think we'll probably use the drug even in IHC zero.
So, and a patient is really run out of options. Would you, if you could access it, or maybe have you ever been able to access TDXD in IHC0 patients? I thought that there were a handful of patients who have been reported to respond with IHC0, but I'm not sure.
That's correct. So there was a study called the DAISY trial done in Europe where they looked at TDXD regardless of IHC expression and showed that even in patients who have HER2 IHC0, some of the patients have a response. So if you're running out of options and if insurance and cost is not an issue, definitely an agent to consider in this setting.
Okay, please continue.
So for this patient, one would consider sacituzumab govitecan. So what is sacituzumab govitecan? It's a TROP2 directed antibody drug conjugate. The antibody is towards TROP2. It has a linker that connects the antibody to SN38, the active metabolite of irinotecan. The ADC can deliver 100 times more SN38 as compared to irinotecan, and that's the advantage of the ADC. In a phase 1 trial, it showed a response rate of more than 30% in patients with hormone receptor positive metastatic breast cancer as well, besides TNBC. And this led to the TROPiCS-02 trial, a pivotal phase 3 trial looking at sacituzumab govitecan or treatment of physician's choice in patients with metastatic ER-positive breast cancer. So what did the trial show? The trial showed an improvement in progression-free survival with sacituzumab govitecan 5.5 months versus 4 months with chemotherapy. These were all patients with metastatic ER-positive breast cancer who had received 2 prior lines of chemotherapy. And then we saw a follow-up update in terms of improvement in overall survival. Sacituzumab govitecan showed a median overall survival of 14 months versus 11 months with standard chemotherapy. So a 3-month improvement in overall survival seen with sacituzumab govitecan in this later line setting. And this resulted in FDA approval of sacituzumab govitecan in ER-positive metastatic breast cancer besides TNBC. Now, how about HER2 status? We were discussing this previously. The drug targets TROP2, so we would not expect that the HER2 status would have an impact on efficacy, and that was seen in the TROPiCS-02 trial as well, that regardless of HER2 status, HER2 low or HER2 IHC0, there was benefit with SG that was maintained against standard of care chemotherapy. Now let's talk about a slight modification in the case. What if you had the same patient, but the HER2 IHC was 1 plus, so that's HER2 low? What would you consider next? I think that's where trastuzumab deruxtecan comes in, and that would be an appropriate agent at this time and probably used before sacituzumab govitecan. And the reason to use trastuzumab deruxtecan is because HER2 low does not mean HER2 zero. Even tumors that have IHC 1 plus 2 plus, there is some degree of HER2 expression, which is sufficient for the ADC to bind to the antigen, get inside the cancer cell, release deruxtecan. It has a bystander effect, so it can impact other cells that do not express HER2. So TDXD is an ADC targeting HER2, binds to the HER2 cell, gets inside, releases deruxtecan, and because of the bystander effect, can impact neighboring tumor cells, including cells that do not express HER2. It showed good results in the phase 1 trial with a response rate that was pretty impressive, more than 30% in 1 plus and 2 plus as well. So this led to the pivotal DESTINY-Breast04 trial. TDXD was a standard of care chemotherapy. Now, different from TROPiCS-02, this was an earlier line of therapy trial. The trial required 1 prior line of therapy, unlike TROPiCS-02, which required 2 prior lines of therapy. The other difference is that this trial did not require prior CDK4/6 inhibitor use, while TROPiCS-02 required that. This was predominantly an ER-positive trial. 90% of patients in this trial had ER-positive disease, and about 10% had hormone receptor negative disease. In terms of the results, met its primary endpoint, very impressive improvement in progression-free survival, overall survival, doubling of progression-free survival, and close to doubling of overall survival. The results were practice-changing and led to the approval of trastuzumab deruxtecan in this setting. Now, besides this, there are other agents in development as well, other agents that target LIV1, other agents that target TROP2, as well as HER3. So in the future, we'll have to figure out sequencing of these different ADCs. And we'll have to figure out whether the sequencing should be based on continuing the same target versus the payload. We looked at this question at our institution, a real world study looking at patients who got one ADC after the next to see if there was a subset of patients who had cross resistance. And it does appear that if you use the same antibody, same payload, you'll have 100% cross resistance, which is not surprising. But if you continue the same antibody but switch the target, a subset have cross resistance. And similarly, if you change the antibody target but keep the same payload, a subset has cross resistance. So we need more data in terms of how to sequence these different ADCs in terms of starting with TDXT and then using SG or some other therapy. Thank you so much for your attention. Hope this was helpful.
What I was curious about is a little bit more about sequencing and HER2 low. So first of all, I noticed that your patient or your scenario there, the patient got capecitabine and then got paclitaxel. Do you usually use those two drugs before you get into TDXD or something else, paclitaxel? Because other people I've heard will go there after CAPE.
That's exactly correct. So the approval of trastuzumab deruxtecan is after one line of chemotherapy. So after capecitabine, I often use trastuzumab deruxtecan as the second line of therapy.
And the other question is, could you elaborate a little bit more about why you use TDXD before sacituzumab and hormone receptor positive HER2 low?
So there are two reasons why I use generally TDXT before SG. The first is based on level of evidence. In Destiny Breast 04, patients were required to receive one prior line of therapy, while in Tropics 02, patients were required to receive two prior lines of therapy. So in general, Tropics 02 was a later trial in terms of line of therapy than Destiny Breast 04. So based on level of evidence, I use TDXT first and then SG. And the second reason is the degree of improvement in progression-free survival and overall survival. The hazard ratios were better with TDXT as compared to SG. And also it's more convenient for patients because it's every 3 weeks versus day 1, day 8 with sacituzumab govitecan. Having said that, we don't have head-to-head comparisons. If you are concerned or if a patient, say, has pneumonitis and you don't want to use TDXT, you have another option with sacituzumab govitecan, which does not cause pneumonitis.
Yeah, that's what I was sort of thinking about. What about in the patient who does not have prior pulmonary, is a regular patient with normal performance status? Does the possibility of ILD make you think more about sacituzumab? Or, in those patients, the risk is so low if you monitor them closely that it's not, a game changer?
Yeah, more the latter. So I usually would start with TDXT, monitor the patients carefully. But if there's a problem, then there's another agent one could use.
And final question, just curious, I know we're talking about hormone receptor positive, but I'm just kind of curious, in the hormone receptor negative HER2 low patient, what comes first, sacituzumab or TDXD?
In hormone receptor negative, I usually use sacituzumab govitecan first and then TDXT, and the reason being level of evidence. In the ASCENT trial, sacituzumab govitecan was evaluated against standard of care chemotherapy, and the trial was dedicated for patients with TNBC. Close to 500 patients with TNBC were studied in that trial. In Destiny Breast 04, only 10% of patients had triple negative breast cancer, 58 patients. So it's about 1/10 of what was studied in the ASCENT trial. So in terms of level of evidence, it's lower. Having said that, ultimately, it's a discussion with patient about these two options.